Thanks for the invitation. I have no conflicts with industry relevant to this talk. So I'm going to start with the cardinal features of how we define Ehlers-Danlos Syndrome. So there's hyperextensibility of the skin, and this varies based on the type of Ehlers-Danlos. Hypermobility of the joints and tissue fragility. And different types of Ehlers-Danlos have different target organs for tissue fragility, whether it's the skin, the blood vessels, the eyes, the gums. And there's many different types of Ehlers-Danlos. So when I was a resident, we had 6 types. And we had genes for 5 of them, sort of understood the inheritance pattern of them, and they all sort of met the same criteria. Then the next go on this had several more types because more genes were being isolated that caused abnormalities of the collagen. And so that's the key point, is abnormalities of the collagen. And then in 2017 came out one classification that tried to narrowly define different types of Ehlers-Danlos and ones that we had genes for. And what came through in this pathway, although there's some controversy, especially with the hypermobile type, what came through in this pathway is that many of the mutations that we see are either the collagen molecule themselves or enzymes that process the collagen molecule, or enzymes and proteins that interact with the collagen molecule and help keep the shape of the collagen molecule. So the genes that are affected, so either the fibrillar collagens themselves, or the enzymes that process them, or the proteins that interact with them. And so there's many, many of these, and I'm going to go through how we make collagen. So there's many different ways you could end up with a problem with your collagen that are genetic. So if the collagen has an abnormality with the molecule, sometimes it doesn't make it out of the cell, and so you don't get enough collagen. We call that haploinsufficiency. Collagen groups up with itself, so they wind up together. So although there can be different genes for collagen, if you have one bad molecule, it can affect the wind up of all of the others within that fiber. And then if you don't process your collagen properly, as we'll see, collagen goes from a very soluble molecule inside the cell to becoming very insoluble and providing strength to the skin outside of the cell. And if you have a problem with making it strong, then that's another abnormality that can lead to Ehlers-Danlos. So what I'm going to do today is review the structure of skin with respect to Ehlers-Danlos, and I'm going to look at the interplay of the different components of our skin. And so this goes through with all the other organs as well. So there's 3 interplays. There's collagen, there's elastin, and then there's all of the proteins and sugars in between. We call that ground substance. I'm going to go through the role of electron microscopy and inherited disorders of connective tissue in general. And then I'm going to do a little bit of a focus on hypermobility spectrum disorder and changes that can occur with an altered matrix. And so how it can affect other cell types in the matrix. And we use the matrix for all of our other cells to migrate in development and how this can affect migration of other cells. So the skin. We have collagen, which gives us the strength in the skin. We have elastin, which is like a slinky, pulls apart but wants to come back together. It gives us the resilience of the skin. And then we have all this ground substance, which is proteins and sugars. And that gives us the moisture, the turgor of the skin, and links everything together. An abnormality in any one component of this can affect the proper assembly of all of the other components. So Ehlers-Danlos syndromes are disorders primarily of disturbed collagen production. So the morphology and the strength of the collagen is compromised for one reason or another. So collagen is the major protein in our body. It's a major protein in the skin, ligament, tendon, and bones. There's a whole bunch of collagen genes, so there's a whole bunch of different ones, 43 genes making up 29 collagens. Collagens are 3 molecules wrapped around each other. That's called a triple helix. And they can be 3 of the same ones, when we call that homotrimers, or it can be 3 of different collagen genes, proteins from different genes, and we call that heterotrimers. Ehlers-Danlos Syndrome skin in different types of Ehlers-Danlos has been described in different ways. A velvety texture, a doughy texture, and this is more dermatosparaxis type, thin skin, like what you might see in vascular type, and hyperextensible skin, like you would see in classic type and its variants. So collagen is the most abundant protein in the body. It's 70% of the deeper part of our skin. And so how we define a collagen molecule, it's got areas where those three proteins wrap around each other together, making that helix. And that helix is really well defined. There's a really tiny amino acid in the center of the helix, and that's glycine. And then you have these bigger amino acids on the outside that have modifications to them to link onto other things. And those are proline and hydroxyproline. So the small amino acids are in the inside, the bigger amino acids are on the outside. And so this is the structural component, major structural component of the matrix. We have two big broad classes of collagen that we divide them up to. We divided them up to the ones that always make that triple helix, and that's it. Those are called fibrillar collagens. And then we divide them up to ones that have little breaks in those helixes, and that way the molecule can bend, and these are called non-fibrillar collagens. And our skin is not just one type of collagen, it's an interaction of many of these different types. So this is a picture of a collagen fiber. And when you look at what's in the collagen fiber, there's different types of collagen. So at the center of the fiber is collagen 5. And so this has a triple helix, but then it has an arm that brings it up to the outside to bind onto other things. And it is the center of the core of collagen. Around it is the majority of collagen 1. And so this is the standard fibrillar collagen from which we know most of our information about collagen. So this makes up the majority of the collagen in the fiber. We have a little bit of collagen that we had when we were a fetus, and that's called collagen 3, the fetal collagen. So this is intermixed in between this. And then binding to these collagens, we have those ones that can bend, these fibril-associated collagens with interrupted triple helices, or facet collagens. So these are ones that can bend and join onto other molecules in the matrix. All of these, each one of these has been described to have a mutation that causes an inherited disorder of connective tissue. So I'm going to start with collagen 5. This was the center of all the collagen fibers in the skin. So it's only 5% of the collagen. It's located at the core of all of the fibrils. And when you have a problem with this collagen, you get these cigarette paper wrinkled scars or atrophic scars. You have hypermobility. You have easy breakthrough of different things in the skin. So this is a ganglion, a very large one. You have fragility of blood vessels. And you can have very funny scar reactions. This is a calcified scar. Depending on where they are, they're called spherules or molluscoid pseudotumors. And you have hyperextensibility of the skin that does snap back because the elastin is normal. And so this is the classic type of Ehlers-Danlos. And so thinned atrophic scars are characteristic. You can have these funny scar reactions, hyperextensible skin, and joint laxity and hypermobility. And it's typically both small and large joints. And so there are two genes that code for collagen 5, and they interact with each other in that helix, and it can be a mutation in either one of these genes. That fetal collagen that is within the collagen fiber is the important one when we're first developing in life. It ends up being 10% of the adult dermis, but it's 90% of the fetal dermis. It's enriched in blood vessels. It forms the scaffold where all of our organs will form on eventually. It's a little bit larger than the standard collagen in the skin, and all of our organs are built on a base of collagen 3. When you have an abnormality with collagen 3, you have small joint hypermobility. You don't typically have large joint. And this is the vascular type of Ehlers-Danlos. And there's two different variants of this that you can see clinically. There's some patients that you can look at and say, you have characteristics of vascular type. So, and this is called an acrogeric variety, where the hands look a little bit aged, the cheeks are hollow, the eyes are pseudoproptotic. Often you don't have well-formed earlobes. And it depends on where the mutation is. So characteristic of this is that it affects right where all of those molecules come together in that rope. And then you can have the non-acrogeric variety. And these are people who you can look at and say, I'm not sure if you have the vascular type. And this is typically a mutation towards the end of the molecule. Typically they have thin translucent skin. And this is the one where, because all of that collagen 3 is forming the scaffold for the organs and the blood vessels, that you can have perforation of organs, rupture of blood vessels. Characteristic, they have easy bruising. And vascular occurrences such as strokes, heart attacks, rupture of organs, and typically have occurred by about age 40 or 50. The most abundant collagen that we have is collagen 1. So collagen 5 at the middle, collagen 3 interspersed, and collagen 1 is the majority of the collagen fiber. So it's 80% of the collagen in the dermis, and it's most of the collagen in the bone. And there are 2 genes that can either form homotrimers or heterodimers. And this is the best study, and this is the one I'll take you through with to show you all the different things it can cause. So when you have a problem wrapping up the collagen together in collagen 1, you can get this condition. And sometimes it's characterized by very blue sclera, as in this patient of mine. And this is osteogenesis imperfecta. So this is a bone disorder. So, but fibrillar collagen 1 problems depends on where the mutation is. So there's many different types of Ehlers-Danlos that are also caused by collagen 1 mutations, from the arthrochalasia type, cardiac valvular type, classic rare variants, vascular rare variants, osteogenesis imperfecta, many variants, Caffey's disease where you make too much bone, sort of a variant of osteogenesis imperfecta, and there's an overlap syndrome where you have features of osteogenesis imperfecta and Ehlers-Danlos. So how we make collagen, so all the other collagens go through this route too, fetal collagen, collagen 5, and I'm just going to take you through how we make collagen to see where things can go wrong, and there's many areas where things can go wrong. So collagen is formed as a precursor. It has to go outside of the cell and be processed and hardened. And there's a lot of steps within the cell where it's being made. So right from when it's being transcribed from the DNA, when you try to make the message to go make the protein. And so collagen synthesis is upregulated at a DNA level by things like vitamin A, vitamin C, ascorbic acid. Retinoic acid is vitamin A. Ascorbic acid is vitamin C. And it's downregulated by certain things like steroids and inflammatory molecules like TNF-alpha. So within the cell, what happens is you get the gene for collagen, it's transcribed into a message. That message then gets shuffled through the cell to a compartment where it's made into a protein. And there's a whole bunch of components that grab that message and try and make it into the protein properly. And so many of these different names to the enzymes, and if there's a problem with one of the enzymes, so this is an enzyme that just shifts the molecule from one side to the other, then you get this. So you can see there's an atrophic scar that's showing an umbilical hernia, showing hypermobility. You can see in the fingers, so small joint as well as large joint in the elbow. And so this is FKBP14-related Ehlers-Danlos Syndrome, one of the more rare ones. And so this is just because the molecule doesn't, just because this protein doesn't work, that shifts the molecule from one side to the other. And so you can get kyphoscoliosis, muscle problems, joint hypermobility, they get hearing loss, and this atypical scarring. Then there's a whole bunch of other enzymes that add on sugars, add on hydroxyl groups, and these are all going to be things that are important to make the collagen molecule strong overall. And you can see that a cofactor for the function of all of these, many of these enzymes, is vitamin C. So this is why one of the recommendations is to take supplemental vitamin C. So if there's a problem with one of the molecules that adds a water group onto the collagen, early on, you get this condition. And so you can see this person has kyphoscoliosis, and this is the kyphoscoliotic type of Ehlers-Danlos. And so this is a deficiency of one protein that's just adding on a water molecule to a specific amino acid. But that will become important later on to cross-link collagen and make it hard. And when you don't have that molecule there to make it hard, then the collagen stays quite soluble. So this is the type of Ehlers-Danlos where you can get globe rupture as well as kyphoscoliosis and generalized joint laxity. So within the cell, the message is turned into a protein and it's wound up into a helix, and then it has to get outside of the cell. And so when it's transported outside the cell, there's molecules there that are involved in that. So what happened was that message was turned into a protein. All these processes occur within the protein to try and make it stronger. They line up, and then they have to be sent outside of the cell. Now, this is a pre-protein, so this is not the final end to the collagen. And you got to process the ends of the collagen to make it into a normal molecule. And those are those little scissors there. And so this happens generally outside of the cell, and there's two different players here. One processes one end, and the other processes the other end of the collagen molecule. And then another player comes in and tightens up the collagen molecule by making all the water groups bind to each other. If you have a problem and you can't cut off the one end of the molecule, this procollagen end proteinase, if that enzyme isn't working, then you get this form of Ehlers-Danlos. And so this form is called Dermatosparaxis type. And this is characterized by very fragile skin. So they can sheet off the skin very easily. It was first described as sheep, and then we found people who had it. They tend to have saggy, redundant skin. They seem to look more like they have a problem with elastin rather than collagen, but it is a collagen abnormality. And the ones who are very severe are the ones that we can identify very easily, but there's probably a lot of people with this who are much more milder than the severe forms. If you have a problem with the sequence of the collagen 1, in that you don't have the site to be able to, for that enzyme to work on, to cut off that end product, then you get this condition. And this is arthrochalasia type of Ehlers-Danlos. So they're missing the sequence to clip off the amino terminus. So the collagen stays with this piece hanging on it, and it can't assort properly with the other collagen molecules. And this type of Ehlers-Danlos is characterized by congenital hip dislocations and very weak muscles in the beginning, and hyperextensibility of the skin, and joint laxity. So collagen biosynthesis, so that was just bringing collagen 1 out. The same thing happens for collagen 3, collagen 5. So when we make the fiber, collagen 5 is at the nucleus, and it's got those little arms that point outwards that bind other things. Collagen 1 and 3 surround it, and then these other collagens, 12 and 14, the facet collagens, bind it and bind to all the other proteins within the matrix. So the other things in the matrix, so remember the dermis is 3 things: collagen, which we just saw, and that gives the strength to the dermis. Elastin gives the resilience, and the ground substance gives the texture. The elastin. So the elastin is formed from the epidermis going down, and it matures as it goes down. It gives the skin resilience. So what elastin is you have a whole bunch of amino acids together that don't like water, and they want to stay together because they don't like water. And then they're mixed with ones that do like water. So you have a whole bunch of ones that don't like water, and that forces them to stay together. They can be stretched out, but because they don't like the water around them, they snap back. Elastin can have effects on the collagen. If it's not formed properly, collagen may not be formed properly. And so elastin defects give us other inherited disorders of connective tissue, such as Marfan syndrome, cutis laxa, Menkes syndrome. There's a whole group of these. The third component is ground substance. And this is the proteins and sugars that hold the water and bind the elastin and the collagen and group up everything together. And so polysaccharide is just another word for sugar. And so they all associate with the collagens and the other molecules, inflammatory messages that sit within the dermis, growth factors that sit within the dermis. These are all held by the ground substance. And there's a whole bunch of these. Some of them are within the cell, some of them are in the cell membrane, and many of them are outside of the cell in the matrix. And there are types of Ehlers-Danlos when one of these molecules is abnormal. So here you can see hypermobility, you can see the pectus carinatum deformity on the chest. And this is musculocontractural Ehlers-Danlos. And this is due to one of the molecules that moves a sugar within the matrix onto a protein that helps attach to the collagen. It's not working properly, and that's called decorin. And you get muscle problems, you get skin hyperextensibility, skin fragility, and you get bony abnormalities. When you look at this on electron microscopy, so remember this is just a protein that wasn't sugared properly. So in this condition, the protein, because it's not working properly, it looks very linear around the collagen. And on the other side is where it should be more curved around the collagen. So linear bridges of these sugared molecules rather than curved. And so you can see that the collagen diameter around on the other side isn't the same as the side without the abnormality. This is one of the newer types of EDS. So this one's not in the classification system yet. So this is a newly described one. And they have features of both vascular type as well as classic type. So you can see the very prominent vascularity on the chest. You can see the abnormal scarring pattern on the knees. And you can see the person here has planus or flat feet. And this is also due to one of those glycosaminoglycan proteins. So it's called an aortic carboxypeptidase-like protein. And so this is one of the ones in that ground substance that's important in binding the collagen. And it binds to blood vessels, it's found in the lung and in the bone. And so they have features of vascular type, classic type, and something new, osteoporosis, thinning of the bones. When we look at an electron microscopy of the skin, this is an introduction to electron microscopy, this is in cross-section. So in the top, you can see that all of those little circles look pretty much the same. So that's a control patient. That's a patient who doesn't have Ehlers-Danlos. In the bottom, you can see there's variability in the size of the collagen molecules. It's not tightly regulated. So you can see there are several that are different sizes. So in Ehlers-Danlos, the genes that we've found so far are either affecting the fibrillar or non-fibrillar collagens, enzymes that process the fibrillar collagens, or they're these proteins that bind to the collagens, the glycosaminoglycans and proteoglycans, and that these influence the shape of the collagen. And this is the role of electron microscopy from a skin biopsy. So normally collagen synthesis is tightly controlled, and collagens are spaced apart appropriately, and they're all pretty much identical in size. There's what we call a periodicity to fibrillar collagen. Inherited disorders of connective tissue demonstrate variation in collagen size and spacing when viewed on transmission electron microscopy. This can be used to support the presence of an inherited disorder of connective tissue. So what we do is we take a skin biopsy from either the upper inner arm or the upper buttock. We want a sun-protected site because sun alters the connective tissue. It causes a lot of degradation of the elastin in the area. We put it in glutaraldehyde, we fix it for transmission electron microscopy, and you can view the proteins up to 500,000 times the size that we can see by the eye. And you can see variations in collagen fibrils. So this is a patient who doesn't have Ehlers-Danlos or an inherited disorder of connective tissue. So at the top, you're seeing longitudinal sections of collagen. That's what collagen looks like. It's got that regular periodicity, those little bands. And in cross-section, you can see they're pretty much all the same size, same distance apart. This is a patient with classic Ehlers-Danlos syndrome. So you can see there are some of these very large dysmorphic collagens. We call these collagen flowers. This is a vascular Ehlers-Danlos patient's skin. And there's variation in the shape of the collagen, and there's also less collagen. So this is a problem with that collagen 3. This is that dermatosparaxis where they didn't have that protein that clipped off the ends of the collagen 1, and the collagen looks really abnormal. And there's variation here depending on how severe the mutation is. So this is a severe mutation. We call this hieroglyphic collagen because it really doesn't look like collagen. This is a patient with hypermobile EDS. And you can see those collagen flowers intermixed in between. One of the interesting things in hypermobile EDS is there's a group of patients that we tend to see this as well with it. And these are abnormalities of the elastin that's also going along with the collagen. And so this is calcification of the elastin on electron microscopy. So it's not specific to Ehlers-Danlos. Other inherited disorders of connective tissue have a problem with collagen too. If you have a problem with elastin or a problem with any of the matrix proteins, you don't regulate your collagen diameter. So osteogenesis imperfecta, we see collagen flowers. Kyphoscoliotic disease, which is a variant of that. Marfan syndrome, an elastin disorder. Loeys-Dietz, and a disorder of a receptor protein that sits within the matrix. Pseudoxanthoma elasticum, another problem with elastin and calcification. Cutis laxa, where you have too little elastin. Menkes syndrome, where you don't have the cofactors you need for elastin. So it's not specific to Ehlers-Danlos. It tells you there's a problem with the matrix. Now you have to keep in mind that there are acquired disorders where a person will make abnormal collagen. So whether you get a problem with the cell that makes the collagen, so a problem with the fibroblasts, and there's a group of these. They're kind of rare: sclerodema, scleromyxedema, nephrogenic fibrosing dermopathy, things dermatologists see. So what I want to talk about now is people who have hypermobile joints on the Biden score. And I'm not sure why this made the criteria. These are piezogenic pedal papules. They're very common in the population. So there was a study that Saul Greenberg did several years ago at sick kids, and he looked at all newborns. And 40% of newborns had piezogenic pedal papules. But for some reason, they made the criteria for hypermobile EDS. So hypermobility spectrum disorder is the new term. And it's many disorders with a common presentation. So it behaves as an autosomal dominant. EDS hypermobile type has been very narrowly defined now. But we see within this group, hypermobility spectrum disorder, generally generalized joint hypermobility. We do use the Biden score as a screen, but you have to look to see, could the patient be hypermobile in other joints? Chronic joint and muscular pain, recurrent joint dislocations or subluxations, and symptoms of autonomic dysfunction, as we've heard today, typically easy bruising. Scars can be abnormal, but they're not those cigarette paper wrinkling scars. Functional gastrointestinal disorders and small fiber neuropathy seems to track along with this. Mast cell disorders are very common, and I would say it's close to 90% within this population. And There's a lot of debate here about mast cell activation syndrome. Mast cell activation syndrome is one end of the spectrum. So I've seen a lot of people with hypermobile spectrum disorder, and I think they all have an abnormality, or very close to all, have an abnormality with mast cells. It behaves like an inflammatory disorder in many patients. And there's some cutting edge research from one lab that I'm going to go to here that may give us a hint at the molecular basis of hypermobility spectrum disorder. So this lab, Zopi et al., they've published over the last 2 years 3 papers, which are excellent papers. They're molecular biology and cell biology papers. And what they did in one paper was they took patients that met the hypermobility spectrum disorder criteria, and they took another group of patients who met the newly defined hypermobility Ehlers-Danlos Syndrome criteria, and they compared that to control patients and to patients with either vascular type Ehlers-Danlos or classic type Ehlers-Danlos. So these are cell biology papers, and they looked at what's expressed on the fibroblasts, which are the cells that make the collagen. And so what it turns out is both hypermobility spectrum disorder patients and hypermobile EDS patients upregulate very specific proteins that are not found in controls, not found in classic Ehlers-Danlos, and not found in vascular types. And these are molecules that aren't normally made. They're made in wound responses. They found that these cells differentiate from fibroblasts along a line to something called a myofibroblast, which is a wound cell. So that in trying to deal with an abnormal matrix, the body has a way of shifting into a wound response or an inflammatory response. So this was not seen in the other types of Ehlers-Danlos. So there are very specific proteins that they looked at, and it was actually very good science. So giving us an insight into what may be going on in hypermobility spectrum disorder. The skin is very accessible, so you can grow these in culture as well. They took fluid from culture from patients with hypermobile spectrum disorder and hypermobile EDS, incubated it with fibroblasts from controls, people who don't have any of the disorders, and they start upregulating these inflammatory proteins. So there's something abnormal in the matrix that causes this wound-type response or inflammatory response. There are many roles of a normal matrix. So the matrix is laid down, and all of your nerves, your muscles, they migrate along the matrix. So migration, maturation, many of your growth matrix. And the matrix stabilizes and can activate other cell types. And so it's not surprising that mast cells seem to be hyper-responsive in Ehlers-Danlos. Mast cells are intimate matrix cells in the skin and in the GI tract, as we heard, at the barrier between environment and us. And so is there an abnormality in the matrix in this wound clear response that has an effect on the mast cells? So in hypermobile spectrum disorder, you can have people that are from dermatographism and flushing, right to people who meet the features of mast cell activation syndrome with recurrent anaphylaxis. Second thing is that nerves are intimate with the matrix. And so we see small fiber neuropathy very common in this group. And so is an abnormal matrix inhibiting proper development of nerves. So this is something that this group has been looking at. From a dermatologic perspective, how do we manage EDS? Well, we don't have a lot of management right now. So we go back to, well, what's the basic science of it? So you can upregulate collagen synthesis by vitamin C, vitamin A. Careful with vitamin A because it's toxic when you get to a high level. Avoid glucocorticoids because these downregulate collagen. Protection from trauma. Avoid contact sports. Bleed more easily. Avoid aspirin. And we found a group of patients, another referral base that I get is hematologists sending me. Could this be Ehlers-Danlos Syndrome? Because they have a bleeding abnormality that I can't explain. Most of the bleeding abnormalities in Ehlers-Danlos, except for vascular type, respond to tranexamic acid. I've spelled it wrong there. So this is something we often recommend around surgery. Suturing wounds. So the matrix is abnormal. We tell surgeons to close each layer independently, so deep sutures or subcutaneous sutures, subcuticular sutures. Generally, you keep the stitches in twice as long, so it's not unusual to go 3 weeks on a leg for stitches, to go 2 weeks on the back. And then additional tape or steri-stripping over wounds. Mast cell stabilization. So we had good talks on this today. There's a whole bunch of things we try to do to stabilize mast cells. And then we think about blocking one of the receptors. Remember, mast cells make many different things. Whether it's heparin, they make serotonin, so you have to block serotonin receptors, leukotrienes. That's a little bit of a gray area because we use non-steroidal anti-inflammatories for that, which can exacerbate mast cell symptoms. So trying to find out, is the person in a histamine, heparin, serotonin, or leukotriene arena, and then trying to direct therapy there. So what I tried to do was show the skin matrix is a well-controlled interplay between collagen, elastin, and ground substance. That electron microscopy can detect abnormalities in the matrixal structure and support a diagnosis of inherited disorder of connective tissue. And hypermobility spectrum disorder has changes in the matrix that likely can exert effect on both the migration and subsequent activity of other cell types. Any questions?